Hello, and thank you so much for joining this YouTube live conversation on coronavirus, the new normal. My name is Gavin Yamey. I am a professor of global health and public policy at Duke University, and I direct the Center for Policy Impact in Global Health in the Duke Global Health Institute. So let me start by just giving you a little bit of my background. I'm a physician who's had quite an eclectic career. After being a doctor, I was a health journalist, then became a public health researcher. And in the work that I do today, I try and wear kind of all three hats, working in global health policy. And really, global health policy, I think, is around trying to achieve large-scale change in global health. The health of the population, particularly to improve the health of the poorest and the marginalized. And I would say that our center, even before COVID-19 hit, was already working on pandemic preparedness. In particular, we had done quite a lot of research on what it would take to get a proper pandemic preparedness system in place, one that is fit for purpose in tackling pandemics. And our research had two large domains. The first domain was country preparedness or national preparedness. So if you're a prepared country, you have a system that can detect outbreaks, that can isolate infected people, that can do contact tracing of their contacts, that can communicate public health messages and so on. So those are the core activities that you need to be able to do. And I would say that a prepared country also has a strong leader that will adopt science-based policies and a strong enough health system that can deliver services without financial barriers getting in the way of people seeking medical help. So that's the national preparedness system. The other research we did was on the global system, global preparedness. And by that, I mean a set of activities that you could call international collective action for health. Transnational actions that benefit all countries, like developing vaccines, treatments, diagnostics, like generating and sharing knowledge worldwide on how to control pandemics, and also on having a strong regional and global outbreak system. And you don't need me to tell you that COVID-19 has showed that this system worked in some ways and in some places, but universally, it didn't protect the most vulnerable, as I'm going to talk about today. And I do want to say right at the outset that of the very many tragedies of COVID-19, our research and research by others had shown that it would have cost, tragically, very little to have put in place the kind of national and global preparedness system that I was talking about. We know that COVID-19 has already had a massive toll on human suffering, on lives, and on the economy, about 400,000 deaths so far, and economists predict that it's going to lead to an economic loss of $2 trillion this year alone. We found in our research that you could have put a proper national and global system in place for just $10 billion a year. So I'm going to just say that again to drive home that message. $2 trillion in losses compared with what would have been just $10 billion of an annual investment. And maybe during the Q&A, we'll get a chance to talk about why didn't we make those investments in time. So I'm going to chat for about 30 minutes, and then I'm going to take some questions from YouTube, and I'm going to address 4 topics. First, I'm going to talk briefly about what this new normal looks like and what it's going to take to end the pandemic, in my view. Second, I'm going to discuss how we can live as safely as possible. Third, as some of you may know, if you've read some of my columns for Time magazine or an editorial that I did in the BMJ, I think the US response has been astonishingly poor, and I want to reflect on how I think we got here in this country. And lastly, I want to just touch on some of the long-range policy questions. How do we protect the vulnerable? How do we protest safely in this pandemic era? So the new normal, where are we today? Well, the number of new cases in some countries is flattening or falling. You saw the remarkable New Zealand success story. New Zealand says it has eliminated community transmission of the virus. In lots of countries, including here in the US, lockdowns have been lifted, and you sort of hear that and think, well, does it mean the pandemic is over? And of course it doesn't. This slide shows that actually we just hit a new global high a few days ago, 136,405 new cases Sunday, June the 7th, mostly in the Americas, South Asia, and South Africa, the new epicenters of this pandemic. The pandemic is still raging. It's a new, highly contagious virus, and the vast majority of the world remains susceptible. So I think the only way that this ends is when the world reaches herd immunity. And I mean the world, I don't just mean one country. So herd immunity is when enough of the population, a high enough percentage of the population, a so-called herd, becomes immune to an infectious disease. It has antibodies against that disease. And researchers have shown that for COVID-19, herd immunity is likely to be about 70%. This is a picture by Alex Brissington from a fantastic children's book on COVID-19 that illustrates herd immunity. In red, you can see contagious people. If none of the population is immune, two of those contagious people go into a crowd, lots of infection. Let's say some people recover and have antibodies, say 20%. You'll see that if those two people go into that crowd, there is less infection. Some are protected. If we can get a vaccine and vaccinate 70% of people with a safe, effective vaccine, that herd now protects everybody if those two contagious people go into a crowd. So there's two routes to get to herd immunity. The first is if you have a large enough number of people who get infected, they recover, and they produce antibodies, so they can't get infected again. I think there's two reasons why herd immunity through natural infection is unlikely. First, we just don't know yet whether being infected and recovering gives you full, durable, lasting immunity. That's the first problem. The second is the percentage of people who have been infected so far and then recovered is still very low. And we know that from a handful of surveys. There's been a handful of national surveys. That's what you want, national seroprevalence surveys, surveys to look for antibodies. And in Spain and France that were really hard hit with COVID-19, only about 5% of the population have antibodies. So the vast majority of the world then is still susceptible to COVID-19, which brings us to the second route to herd immunity, which is COVID-19 vaccines. Now, it is, of course, thrilling to see that vaccination efforts for COVID-19 have moved really on the fastest trajectory in history, though I have to say I fall in the camp of researchers who think that it's still going to take us perhaps years before we see the kind of mass global deployment of vaccine needed for herd immunity. Don't forget, the fastest vaccine development in history was 4 years for months. I do think it'll be shorter than 4, but I think that just puts it into perspective. Nevertheless, we are seeing rapid progress. China shared the genetic sequence of SARS-CoV-2, the new coronavirus that causes COVID-19, very quickly at the beginning of January, January the 12th to be precise, and just 63 days later, March the 16th, 2020 in Seattle, the first human trial began. That is really amazing, really extraordinary. And then 2 days later, a trial in China kicked off. And now we have 133 vaccines under development. 10 of them are in human trials. This is a slide from Gavi, the Vaccine Alliance. It doesn't show, obviously, all of those candidates. It just highlights a few. You will have probably read about some of these ones, the University of Oxford candidate in the US, Moderna, Novavax, Inovio, many in China, Australia, and other places. We do have to remember that just because there's 133 candidates most of those are going to fail at an early stage of development. There's a very good chance, though, that a handful will make it through all the way through the development pipeline to launch. But even if we develop a safe, effective vaccine, let's say by 2021, 2022, as many scientists think is possible, not all, but many, there is no guarantee right now, none, that it will reach everyone who needs it. And by that, I mean everyone worldwide who needs it. And there's a really serious risk that rich countries are going to monopolize the vaccine and poor countries are going to be left behind. And obviously that behavior by rich countries would not only be deeply unethical and immoral, it would actually be a way for them to kind of impede their own health and economic recovery. And that's because we have to end viral transmission everywhere on the planet. If there's viral transmission anywhere, it could lead to viral transmission again everywhere. So just protecting your country alone, it's really not going to be good enough. And this risk that I'm talking about isn't just a theoretical one, right? It happened before in swine flu, 2009, I think it was. Many countries, the US, China, other rich countries, they actually monopolized the vaccine. They went into their own one-on-one purchase agreements with vaccine manufacturers. And we have already seen this for COVID-19. We've already seen countries like the US do deals with vaccine manufacturers to make sure that American citizens get the vaccine first. And this kind of vaccine arms race won't cut it. We're not going to reach global herd immunity with that. So we really need a plan in place now to make sure everyone worldwide who needs the vaccine receives it free at the point of care. So what kind of a plan would that be? What would a plan like that look like? And our research team has been really studying this plan and thinking through the ingredients of the plan. And clearly, you would need three key components. The first is that you have to share the knowledge. If you're a company that develops a safe, effective vaccine, you have to, I believe, share the know-how with manufacturers worldwide. There is no single manufacturer on Earth, not one, that can make enough vaccine for the whole planet. We're going to have to globalize the manufacture of successful vaccines. We also need to remember, and I feel very passionately about this, and not everyone agrees, but I really do feel this, that nearly all these vaccine efforts are being funded by public money. We are paying as taxpayers. And so I do think that those who develop and manufacture the vaccine have a duty to make that vaccine publicly available. That's the social contract, I think, that they entered into. I think the intellectual property, the patent, if you like, should be placed in an open patent pool. And I think everybody needs to support the necessary arrangements to transfer the technology to manufacturers worldwide. And I agree with Emmanuel Macron, who said COVID-19 vaccines must be a global public good. So that's the first thing. Secondly, the world needs to club together into a sort of a global buyers club and purchase enough vaccines for distribution worldwide, with every country, I think, paying according to its means. The rich, of course, paying the most, the poorest countries paying nothing. We should subsidize the poorest countries. We're going to need billions of doses, and we're all going to need to collectively buy those. And thirdly, we've got to make sure that when it comes to distribution, the vaccine is distributed in a way that makes sense from a public health point of view. We've got to maximize global public health impact, and it must be equitable and fair. So, for example, it would make sense within a country to make sure that your first doses go to health workers and other essential workers first. They are putting their lives on the line, to the medically vulnerable who are most at risk, and then to the wider population. And between countries, we're going to have to acknowledge that if there's a an outbreak, an uncontrolled epidemic in one part of the world, clearly that part of the world is going to need doses more urgently. I also think, though, that, I've said this earlier, we've got to be honest with people, that I think it is going to take time to develop an effective and safe vaccine. And I honestly think that if we rush it and we roll out an unsafe vaccine that causes harm, we will end up threatening our efforts to end the pandemic. And really, with that in mind, I think it's absolutely deeply unfortunate that President Trump has named the US vaccine Operation Warp Speed. I really wish he hadn't. You know, the anti-vaccine movement, such a dangerous, dangerous movement, it commonly says that vaccines are rushed to market and not properly tested. And there's already plenty out there, particularly in social media, from the anti-vax movement saying, you know, COVID-19 vaccines are going to be dangerous, they're being rushed through. And so I think naming it Operation Warp Speed has really given fodder to that movement. We've got to build trust now. We need, you know, 70% of the population who will agree to be vaccinated to reach herd immunity. Predictions are hard, obviously. I am humble about my own attempts at prediction, though I do suspect, I hope I'm wrong, but I suspect we are some years away from herd immunity. So that means the new normal is going to be living as safely as is possible. And the good news is that there are many countries that have successfully controlled their epidemics, and they're really showing us the way on how to do that. They've crunched the curve. Then they've had excellent test and trace systems in place. You do surveys to look out for hotspots of infection that you can shut down quickly, and then you can gradually reopen your economy. I think the key there is being able to put out these small fires quickly, and also recognizing who is vulnerable and who needs protection. And so, for example, South Korea is rightly hailed as a country that did one of the best in controlling COVID-19. They very quickly developed a free test. They rolled it out nationwide, including through drive-through testing, which you can see in this picture here. They used a world-class test and trace system using GPS to identify cases, isolate them, quarantine the exposed. And their leaders were absolutely brilliant in communicating with the public every day on what was actually happening. They brought citizens along with them. And then you may have read this, that in early May, they started to see some cases after they'd loosened social distancing restrictions. They'd opened up clubs and bars again. They had a cluster of cases in the Itaewon district in Seoul, a cluster of cases in a couple of gay nightclubs. And they acted really fast. They were able to very quickly put out the fire. They did 65,000 tests. I mean, that is just extraordinary to get your head around. Aggressive contact tracing, and they managed to get new daily cases back down to the single digits again. And so I think that's what the new normal looks like in a country that has succeeded. They loosen restrictions, they are very vigilant, they see a small fire, they put it out again, they tighten restrictions, bars and clubs were closed again. I think we're going to see these cycles of opening and tightening, but it means that you have to get the virus under control first, and that buys you time to put in place a world-class test and trace system. You have to, at a bare minimum, I think, see new daily cases falling for at least 14 days, most researchers would say. Test and trace, you get your hospitals ready in case there's additional surges. You provide high quality personal protective equipment to every health worker, and then you monitor very closely what's happening, and you use local data to kind of pinpoint where those flare-ups are. And most of us by now have probably heard of this number, R0, the basic reproductive number, which can be helpful in monitoring progress. So R0 is the number of new infections that stem from a single case. If, for example, you have an infection and you pass it to 2 people, then the R naught is 2. So in the R naught is 2. So if you look at COVID-19, you'll see that for COVID-19 it's between 2 and 3, probably 2.5. So on average, every person with COVID-19 will pass it on to somewhere between 2 and 3 people in a susceptible population. And you can see from this picture that that is higher than seasonal influenza, but lower than SARS or measles. For COVID-19, what we want to do is we want to see the R naught fall below 1, because that suggests that the number of cases is shrinking. And so that gives you more confidence that you can open up your economy again. And when R naught is going above 1, it indicates that your number of cases is growing again. And ideally, you would reinstate control measures. An even more valuable metric is RT, the effective reproductive number. So R naught tells you essentially about a disease's potential. COVID-19 has the potential for spread from every 1 person who's infected to between 2 and 3 people. But if you put control measures in place, like stay-at-home orders, for example, the actual or effective transmission rate, you can drive it down. That's RT, the effective reproduction number. So that's the virus's actual transmission rate at any particular time. The T means time. And so Denmark is a very good example of a country that's used this effective reproductive number, RT, effective reproduction number, to monitor what has happened with schools reopening. So Denmark is an example of a country that crunched the curve. It had a lockdown, one of the earliest lockdowns in Europe, actually, March the 12th, including school closures. And you can see at the time, its RT was around 1.5. And then you see the RT falling really quite sharply. And when it was about 0.7, they reopened schools, April 15, and they watched very carefully to see what happened. And I remember over the next few days and so on and weeks, there was some nervousness because the RT kept creeping up. It fell back again, as you can see, and so they didn't need to reopen schools. So again, Denmark was watching carefully. It had a system in place. It knew that it was ready to put lockdown measures in again, kind of another fire extinguisher if needed. It was following the RT. That's what a new normal looks like in a country that's been effective at tackling COVID-19. And clearly here, I've been talking about the big picture, right? What do public health officials kind of need to be doing to monitor, to look for flare-ups? But there's also very specific science-based guidance on reopening safely. So for schools, for example, in Denmark, the children are all in little groups or cocoons. Those cocoons don't mix. The cocoons arrive at school and leave separately. They don't eat their lunch together. They are taught by just one teacher. The idea is to minimize exposure. So that's where we are. But I think it's quite important to also reflect on where we've been. And there is a perception out there, you do hear it, that really the US, there's nothing we could have done about our epidemic. I've heard people say, well, it's a big country, what did you expect? That is entirely false, absolutely false. There's a reason that the United States has the largest number of cases and the largest number of deaths in the world. This was a preventable catastrophe, a moral catastrophe, I would say, as I will reflect on now. It's now almost 5 months since the World Health Organization, the WHO, told every country on earth, every single country, to get ready for transmission of the new coronavirus. It's coming, they said. To be completely precise, January the 23rd. That is when every country knew it was coming. This is specifically what it said. All countries should be prepared for containment, including active surveillance, early detection, isolation and case management, contact tracing, and prevention of onward spread of this new virus. And a week later, it it declared a public health emergency of international concern, the highest level of emergency. So we knew, and what you can see looking back, of course, is that countries took very divergent paths. Clearly, some countries followed the advice, their leaders, they adopted a science-based approach, they communicated their citizens, they got ahead of their virus, they kept death rates low, mass testing, isolation, contact tracing, stay-at-home orders, face masks, healthcare facilities being readied, PPE for health workers. And so if you look at a world map, this is of deaths per million, the death rate. It's a patchwork worldwide. Some countries did really well at keeping their death rates low. In Europe, for example, Austria, Germany, Greece. In East Asia and the Pacific region, Australia, China, Hong Kong, Mongolia, New Zealand, Singapore, South Korea, Taiwan, and Thailand. Many of us have also read about Iceland's success story. Vietnam, 96 million people, 0 reported deaths. So countries adapted early and effectively. On the available information at the time, were able to really avoid the worst of the pandemic. Those that didn't, the UK, the US, Brazil, Russia, they now have the highest number of cases in the world. And if you look at those 4 countries with uncontrolled epidemic and the men who lead them, you might conclude something about their leadership style, their view of the world, their attitudes towards science and scientific guidance. And I have to say, I'm really deeply worried, I'm afraid, about the US, because we still don't have a national, concerted, aggressive plan. We don't have a national, aggressive, robust response to COVID-19. We're an epicenter of the pandemic. We have 30% of the world's cases, just 4% of the world population. 20 states have rising numbers of new daily cases. 8 states, at least 8, have got increasing hospitalizations. It doesn't even look as if we're out of our first wave. This week in Time magazine with my colleague Dean Jamieson, UCSF, we wrote a piece on how the US death rate is now over 100 times higher than China's death rate. Let that sink in for a second. The death rate here is 100 times greater in China, where the virus first emerged, and where, of course, Trump believes blame should lie for letting the US epidemic get out of hand. So how did we get here? You may have seen with my colleague, Greg Gonsalves, a very inspirational activist, MacArthur Genius Award winner, public health researcher at Yale. We wrote an editorial that had a very subtle title, Donald Trump, a Political Determinant of COVID-19. And I have to share that Greg and I found it deeply depressing doing the research for that piece. We went back and documented most of the missteps that the Trump administration made leading to this catastrophe. You saw South Korea following the advice of WHO, listening to scientists. You see Trump failing to act. You see him downplaying the threat, falsely reassuring the public that one day this virus would just disappear, denigrating science and scientists, flouting bizarre ideas about bleach and inhalation and injection of bleach, refusing to wear a mask, really very damaging, urging his supporters to, quote unquote, liberate the states from stay-at-home orders, and you saw that they did that. They marched with guns to state capitals without masks to demand the ability to go to the beach or get a haircut. The federal government should have really been getting a system in place from January the 23rd of mass testing, contact tracing, producing personal protective equipment for essential workers, setting up clear chains of command between the federal government and states. It didn't do any of those things. And of course, the Trump administration dithered on social distancing. There were so many times that many of us literally were in tears. I think one of the moments that really hit me was when the US government, we had practically no PPE, personal protective equipment for health workers, the official US government response was that health workers should stick a bandana over their faces. That is a disgrace. So for at least 6 weeks, January to mid-March, the virus was basically just given a free pass to spread nationwide. This was by mid-April, it was everywhere. And clearly this was the worst public health failure in a century. And I agree with my colleague Greg Gonsalves, who said that any president, Republican or Democrat, any president would have done better than Trump. And the situation has improved somewhat, but there's still very little sign that the federal government is mounting the kind of urgent nationwide coordinated response that we're going to need to reverse the current trends. The White House coronavirus testing czar, Admiral Brett Giroir, he's standing down. There's no plans to replace him at all, even though we're still really far short of the number of tests we need per day to safely end social distancing. Yes, we're doing better. We're probably at somewhere between 300,000 and 500,000 tests a day, depending upon the source that you use. But research at Harvard has shown that we're going to need up to 10 million tests daily. There's not enough contact tracing in place to bring the virus under control. If we assume, for example, that you need, let's just say conservatively, 5 contact tracers for every new case, only 8 have enough tracers. And we've got a patchwork of state policies right now, and often very contradictory messaging on social distancing, on face masks. And that contradiction, that patchwork could potentially amplify harms to the economy and to human health from this already delayed initial response. So lastly, in just the last few minutes, let me reflect on some longer range policy questions. Where do we go from here? And I think the most important thing that I would say is we desperately and urgently need to protect those who are most vulnerable. The virus has disproportionately ravaged Black and Latinx communities here in the US, as you can see on this graph of death rates. And research has shown the many reasons why. Structural racism, the legacy of slavery, the pervasive injustice of redlining, the grotesque practice of literally outlining neighborhoods that had sizable Black populations in red ink on maps as a warning to mortgage lenders. Worse access to healthcare, worse living conditions, lack of health insurance, and of course, much, much greater exposure to the virus. Here I am a privileged white professor with an income, and I have had the luxury of, as I am today, working ensconced in my home. But who has been delivering our mail? Who has been caring for people in nursing homes? Who has been driving our buses? Who has been in Amazon warehouses and meatpacking warehouses? Who has been caring for our sick in clinics and hospitals? Disproportionately, it has been Black and Latinx Americans. And too often they have not been given the high quality personal protective equipment that they need, like visors and N95 masks. And we've seen horrific outbreaks in nursing homes, in prisons, in jails, in ICE detention centers, in juvenile detention centers. And I would just like to say, shut down ICE detention centers today, shut them down. Or those who are living on the streets, all of these people are at high risk. We've seen awful outbreaks as well in Native American communities. We've got to protect vulnerable populations, not just because it's the right thing to do, the just thing to do, the ethical thing to do, but actually it makes us all safe again. And we've seen that in Singapore. Singapore, another country hailed as doing spectacularly in controlling its epidemic. But guess what? It forgot about its 200,000 migrant workers who are living in appalling conditions, packed dorms, 10 to 20 people in a room, and the result, an outbreak amongst migrant workers. And that's why prison health is public health. Those outbreaks will spread beyond prisons. Homeless health is public health. Migrant health is public health. And I think the most important word right now is solidarity. To keep the pandemic at bay whilst we're waiting for a vaccine, we all have to do our part. And I think that there's two kinds of solidarity that matter. There's the individual solidarity and the community solidarity. In terms of our individual behaviors, obviously in a pandemic, the decisions that we make as individuals affect other people. They have consequences to the community. So you may think it's okay not to wear a mask, you're willing to take the risk yourself, but you're putting others at risk, including vulnerable people, when you don't wear a mask. And that's why it's been really so troubling to see sound evidence-based public health advice being politicized when President Trump refuses to wear a mask because it's not manly or macho. He is sending a very dangerous messages to his followers. You know, he's implying that wearing a mask is a weird sign of weakness. And whether we are Republicans or Democrats or independents, we all need to be heeding safety messages right now, like the 3 W's: wear a mask in public, wash your hands, wait 2 meters away. And then as a community, we're going to need a new kind of social movement, what Greg Gonsalves and his colleague Amy Kapczynski have called a new politics of care. And that movement is about solidarity in pushing local, state, and federal leaders to protect the vulnerable, to ensure that Black, Latinx, and Native American communities get access right now to free testing. And if they need isolation or quarantine, give rent and food assistance. A push for universal health coverage, for universal sick pay. And when we have a vaccine, ensuring everyone who needs the vaccine gets it. And I want to just close on one final reflection on the new normal. And that's the new normal of protests against racial injustices. When the pandemic first hit, there is no one, I think, who could have predicted that the largest protests worldwide in history, the protests in support of Black Lives Matter, would happen in the middle of this pandemic. Black Americans have died of COVID-19 at 3 times the rate of white Americans, and yet COVID-19 testing sites have favored white communities. Black Americans continue to die of other diseases, heart disease and cancers and asthma, at higher rates than white Americans. And on top of this festering wound of racial disparity, the police and armed vigilantes have been assassinating Black Americans day after day after day after day. 1 in 1,000 Black men and boys in the US will be killed by the police. There are Black physicians who tell me they are afraid to drive to do a shift in their hospital at night. They are afraid that the cops will assassinate them. And this week alone, virtually no media coverage, 2 Black trans women were found dead, presumably murdered, just this week alone. So in these inspirational protests against these injustices that I don't think are going away anytime soon, I see the demands for that politics of care that Gonsalves and Kapczynski talked about. And that gives me hope. But at the same time, of course, we can't pretend that from the point of view of the epidemic, protests are risk-free. They're not. Of course, there's a risk of viral transmission, but the messages remain the same. Reduce the risk to yourself and others. For example, wear a mask, keep moving, use noisemakers instead of shouting, stay distant or be in a cocoon of people, wash your hands. And the police need to stop putting people at risk. They must stop using tear gas. They must stop using pepper spray. They must stop kettling crowds, squashing them together. They must stop putting people into close contact in police cars and in jails. They need to be distributing masks and not shooting rubber bullets. And I think the very wonderful Elie Mystal, who is the justice correspondent for The Nation, said it so well. Get your hypocrisy takes out of my face. Protesters should wear masks. The police should stop beating the masks off them. And MLK did not die so white people could get a tan at the beach during a pandemic. People are taking to the streets to protest a different kind of pandemic that has lasted 400 years. So safer protesting will also, I hope, be part of the new normal. So thanks for listening so far. I wanted to thank my team at the Centre for Policy Impact in Global Health, and also Michael Penn, Communications Director at DGHI, for supporting all the work that we've done on COVID-19. And now I'm really looking forward to answering some questions. I am going to go to my chat screen, and I'm going to take a question from Alex. How are the global communities working together? Are they working together? Thank you, Alex. That's a great question. So I think that I'm an optimist, and I'm seeing some very promising signs of collaboration. For example, the EU held a pledging conference recently where nations came together to pledge $8 billion for coronavirus control efforts, including the development of control tests. We've seen unprecedented scientific collaboration. We've seen the launch of a new mechanism called the COVAX Advanced Market Commitment Mechanism from Gavi, the Vaccine Alliance, which is in some ways an attempt to kind of put into operationalize the principles that I mentioned. The world comes together, buys a pool of vaccine, distributes it fairly. So I think many, many examples that give me hope. At the same time as Mike Ryan, who you've probably seen on television almost every day, who's leading the emergency response to COVID-19 at WHO, has said that distributing this vaccine, raising money for it, manufacturing it at scale is probably going to be the greatest logistical challenge in a generation, or perhaps forever. And there are going to be some competing national priorities. And that's what I worry about. As I said earlier, I worry that there are countries who might want to go it alone. I hope they don't do that. I hope countries don't sit it out. Obviously, the WHO is under fire from the United States. The United States, President Trump in particular, is playing politics at a very dangerous time, saying that the US will withdraw from the WHO during the worst pandemic in a century. I can't think of anything more bizarre, unhelpful, and pathetic, to be honest. So there's clearly some signs of nationalism that worry me, but I've also seen signs of optimism. So here we go. Wow. A very easy question that I think might come from Matthew Cohn, one of the most inspiring high school teachers from Carrboro High School, the Jaguars, go Jaguars, who, by the way, has been leading a long-standing series to bring speakers in from all over the world, often remotely, to talk to high school students about social justice and global justice, and he's done an amazing job. And he asks, how can we persuade the Republican Party to change course on COVID-19? It's a very easy question to answer. It's a really hard question. I mean, as you've seen, there has been very little breaking of rank from Trump. Mitt Romney marched in a Black Lives Matter protest. I know that some people were skeptical. I personally feel, give credit to where it's due for Romney to doing that. There have been some governors. There have been some state governors, Republican governors, in Massachusetts, for example, who have been ahead of the curve. I would say there's more hope from governors and perhaps at the local and state level than in terms of Congress. Do I think that there's going to be some kind of mea culpa, some kind of change of heart from the Republican Party with months to go before a general election? I think not. And although I said that the US death rate is now 100 times China's death rate, I'm very sad to say I think that we could be on our way to 200 if Trump is re-elected. And I think that this new politics of care needs to be at the local level. We know actually what it takes to put the virus under control and to try and live as safely as possible. These steps that I mentioned before, these are old-fashioned public health tools. Until we get a vaccine, which also, of course, is an old-fashioned tool, but we don't have one yet. That's probably the closest thing to a technological breakthrough. We need a social breakthrough. We need to as a community together, find a way forwards. And I have to say that, it really pains me. Obviously, President Trump has the largest megaphone in the country. And all that time that he was spouting weird conspiracy theories, promoting hydroxychloroquine, where there's no evidence of effectiveness, the bleach stuff, the all of that business. If he'd only put that energy into promoting universal health coverage or paying people who are at home, into a social movement, we wouldn't be where we are today. And I think that kind of, politics of care, that kind of new social movement with communities coming together, with action being taken at the local level, masks, social distancing, building contact tracing locally. I think President Trump cannot and will not come to save us. As Gonzalez and Kaczynski have said, we are alone with this virus. But it's not that we're alone, of course. It's just from the point of view of President Trump, we're alone. He ain't coming. There is no cavalry. There is no Trump cavalry. Really, I would say it's quite the opposite. He's an impediment to progress. And the lives of many people, are down to his incompetence, for sure. And I think that that's what it's going to take. A question about, wow, I don't know if I'm going to take a question on artificial intelligence. I'm going to be humble that my knowledge of artificial intelligence is not enough. However, so this is whether artificial intelligence is going to save us. Well, it's not really. It's about whether it's going to contribute significantly to ongoing vaccine development efforts. Let me try and briefly tackle that as someone who knows very little about this topic. We are doing a project, our center, the Center for Policy Impacting Global Health. We are doing a study right now with colleagues in Germany, a group called Open Consultants, and with Policy Cures Consulting in Australia and others. Very large project. We have partners collaborating with us in Kenya, South Africa, India, and China. It's a project to try and understand the role of some kind of new pooled mechanism or aggregator mechanism, if you like, for late stage trials of new technologies, including vaccines. We are exploring the notion of whether pooling resources and pooling knowledge and pooling know-how could speed up the development of critically needed health technologies, medicines, vaccines, diagnostic tests for neglected diseases and emerging infectious diseases like COVID-19. And we have been looking at the literature on artificial intelligence, machine learning, so-called highly efficient clinical trials. And I would say the data are early still, but that these tools could potentially drive efficiencies. They could potentially speed up product development, make it more successful, help us to choose the winners or the products that are more likely to win early on. So I would say it's a promising area. Mandating of mask use. Are there any policies? It's a great question. The UK is mandating mask use on public transport. I think June 15th or thereabouts. the work on face masks, I need to just give a shout out to Trish Greenhow, Oxford University, amazing family doctor and professor who has been tirelessly synthesizing, collating the evidence on face masks, where, of course, we don't have perfectly conducted, randomized controlled trials that show without a doubt that face masks, have a massive effect. But we have enough evidence now to show that face masks can reduce transmission and everybody should be wearing one in public. I think the example of the mandate on public transport is really helpful, and I know that she played a huge role in getting that through. Conspiracy theorists. Oh wait, no, there's more. Quitting the WHO. Okay, so yes, the US, I think, as I said before, I think it is a bizarre decision for the United States to quit the WHO. Let's not beat around the bush here. The largest number of cases, the largest number of deaths in the world, around 6 weeks at least of inaction by the Trump administration. And here we are, an avertible catastrophe, the greatest public health failure in a century. And Trump has literally said that he, takes no blame, that he didn't do anything wrong. And now he is casting around for blame. He has literally blamed, I think, let's see, Nancy Pelosi, President Obama, China, Democrats, the WHO. The one thing that he has not done is to look at the faults within the administration. So I do think this might be some bluster around, leaving the WHO. The WHO has been through many reforms. It could be strengthened. It could learn all the time, as indeed every organization can and should. But it provides an extraordinary global mechanism for the sharing of knowledge, the generation of knowledge, for the establishment of guidelines, so-called norms and standards around the world. It helps to prioritize research. It helps to coordinate research. If you visit WHO country offices, which I've done in many parts of the world, the technical advice, the scientific advice that the WHO provides is invaluable. Too often, when the media have done stories about the WHO or about the US pulling out, too often they've called me, another white man sitting in a rich country, and I've said, go to countries, go to low and middle income countries, talk to communities, talk to health officials, and you'll see what a gem the WHO is. So I hope that it's just bluster from the WHO. And I do think that this is obviously, I'm not a psychologist or psychiatrist, but Trump is projecting his own failures, I would say, on others. Instead of not just acknowledging the huge number of catastrophic missteps that the administration took, but doing nothing to correct those. I literally don't see an aggressive, concerted, nationwide plan to get us out of this mess. And there are many people who say, well, that some states are doing okay, and it's down to the states now. Really, it's the federal government that has the financial might. It's the federal government that really has the ability to sort out supply chains, to figure out where the supply chains are weak. It's the federal government that really should be leading this, and they have disappeared from view. And of the many tragedies, as I've said, of COVID-19, another tragedy that many have commented on has been, we had one of the finest public health agencies in the world in the United States Centers for Disease Control, but they've really, they've been quite silent, which has been awful. Or the Trump administration has silenced them. It is widely known that the CDC was, going to put out high quality guidance on reopening America, and the administration shut that down. There was going to be guidance from the CDC saying it really wouldn't be safe to have people packed into churches for prolonged periods of time. Trump administration reportedly made them take that out. So this sort of political interference has been very damaging. Conspiracy theories and the anti-vax movement. So, you know, I would like to give a shout out to Lavanya Vasudevan, Duke Global Health Institute. She is really, I would say, one of the people at the forefront, certainly at our university, looking at vaccine hesitancy and the anti-vaccine movement. Peter Hotez is another one. You know, I think I don't know how this is going to play out. I've been encouraged by surveys. Many of them have been media surveys. I think we need to see more rigorous research. I know Lavanya is planning some. I've been heartened by what seems to be high levels of support for vaccination, actually across party lines. I'm hoping that COVID-19 could be a massive blow to the anti-vax movement, and the vaccine deniers will see. So then there's the school reopening question. Very good question. I think that that there are some basic principles on reopening. You may have seen Professor Sally Permar, pediatric infectious disease specialist at Duke, wrote a beautiful piece for USA Today. Shout out to Sally. Please take a look at it, Permar, P-E-R-M-A-R, and about this question of schools, whether they should reopen. I also, with a colleague of mine in Canada, Prachi Srivastava, we wrote an op-ed for a Canadian newspaper, and Sally kindly gave us some advice. There's two broad principles, I think. One, look at what's happening to the epidemic locally. Are we seeing, you know, a sustained fall in cases, sustained fall in hospitalizations, and so on? So does it look like the epidemic is under control locally? And then what are the steps that are being taken, right? I mentioned what Denmark is doing. Small pods of students, no mixing of pods or cocoons. You may have seen the many examples from other countries like China, temperature checks, face masks, teaching outside. Damn, the heat here in North Carolina is a problem, but we do know now scientifically that it is much harder to be infected outside than inside. You know, it's inside enclosed spaces, poor ventilation, that has a much higher risk. So classes outside, no mixing of pods, staggered class sizes. There are some countries, or really I think it's more sub-national regions of countries that have done an interesting thing, which is to have 2-week breaks. So have class, 2-week break, class, 2-week break, which the idea there is that in some ways you're then kind of quarantine people for 2 weeks to quarantining kids. So I think it's a question, I think it's two-part. It's what's happening to the epidemic locally, and then what measures are schools putting in place to protect people. I think that we can say on balance, probably you've seen that children can get sick. There is a rare syndrome. It is rare. Children probably can transmit to adults. The risk of that transmission isn't well quantified, but clearly there is a risk for transmission to families, to bus drivers, to the community. So it's really about taking the precautions that I mentioned so on earlier. The last question from Stephen Welsh, oh my word, who I went to medical school with, who is a pediatric infectious disease doctor, WHO, World Health Organization advisor, and runs the HIV pediatric service for the Midlands region. Remarkable, inspirational human who has given me so much support and guidance throughout my life. I've only got 30 seconds to answer his very brilliant question about what have we learned that we could do differently. Actually, I posed that right at the beginning. You know, why didn't we put in place a pandemic system earlier? I think that back then it was an out of sight, out of mind problem, that making those investments against other priorities didn't make sense. Now, I think we've seen the devastation. We've seen what it's going to take now for all countries to act in the way that the South Koreas of the world, for example, acted. Now, it's true that those nations had been primed, if you'd like. South Korea had a terrible MERS outbreak. Other nations had a SARS outbreak. They put in place national pandemic preparedness systems. That's what it's going to take for each nation. And worldwide, our research team has been doing years of research that has, to be fair, fallen largely hasn't been acted on, showing that we need a global public goods system in place. We need to start to get serious about investing in research and development, in global pandemic preparedness, in stockpiling of vaccines, of personal protective equipment, of really a serious effort around international collective action. And if anything can come of the current global catastrophe, that kind of international collective action, I hope, is what we see next. Thanks, Steve. And thanks to all the fantastic questions. We are out of time. I really, really appreciate that you joined us for today's talk. I think it has been recorded, and we can send the link around. And that really is just left. It leaves me to say, thank you and stay safe, and goodbye.